Thank you. Let me begin by thanking Steve for this amazing conference he's put together and this opportunity for us all to discuss one of the prevailing and the biggest problems that healthcare applications of AI face today, which are the LLMs. When I was discussing with him about this conference and the themes in these conference, we were having a chat and I said, the biggest problem is so many of these healthcare applications are built on LLMs. And if we can discuss what needs to happen, what kind of improvements are needed, I think one of the speakers just talked about garbage in, garbage out. So that's what is the scenario in my opinion, because I am working on a company. I am a founder and CEO of a company called Vignettes. And that's exactly what we're doing. We're trying to build or fine-tune LLMs to create a number of physician-facing as well as patient-facing solutions. So in that process, we've encountered so many problems, and all my panelists here are also based on my review of their background. They are also in similar niches. And I would like to understand what problems exist today in healthcare-specific LLMs, and what are the future directions, and what do we need to improve to make these a resource that the entire field can fall back on. So what I'm going to do is, I'm going to ask all of them to introduce themselves in a very, not based on what is reflected on the slide deck behind us. I would rather ask them a specific question about what kind of solutions are they building, what kind of LLMs are they using to build those solutions, what problems are they facing. And if each of them can talk about a couple of those problems and how are they solving those problems, that would be the right and correct introduction in my opinion. Over to you, Vijay.
Great. Yeah, I'll get started. I'm Vijay Karunamurthy. I'm the field CTO at Scale AI. We are an 8-year-old startup based here in San Francisco. We are known as a data foundry for AI model development. So we've long supported development of more secure, trustworthy AI models, starting with our partnership with OpenAI, which led to the launch of ChatGPT. We've focused on getting expert feedback on how models perform so that you can trust in the answers those models are giving. So a core part of what we do is evaluation and benchmarking of AI models used in systems together with real-world data. And that requires a lot of important fine-grained expert feedback. So we do this for many different disciplines, but in our work in healthcare in particular, we have focused on a lot of real-world use cases where AI models could make an impact, but in order for them to actually live up to their promise in the real world, you need to benchmark how those models perform today. And so it's great hearing from Dr. Mishra in the past presentation some of the really important use cases where AI could play a role. I would say continuity of care is a really important one that we're focused on, being able to look at patient data and patient profiles across a number of different visits, across a number of different exams, tie together all of that unstructured data, pass on enough information for the next clinician to understand where the patient stands and have a more insightful visit with the patient. That's a great, promising use case, and yet in order to deploy that in the real world, you have to evaluate how those models perform in a variety of different scenarios. Do they handle radiology data correctly? Do they handle maybe transcripts of audio notes correctly? Do they synthesize that information and pass the important information to support, for example, disease progression for diabetes in the right way that someone knows this is an intervention that patient already tried, this is a way it fell apart. And building those benchmarks is an important first step for us to see more impact of this in the real world.
Could I ask a follow-up question to Vijay?
Yeah, of course.
So that was interesting what you said. So there are two issues that you touched upon, which is initially transfer of data and analysis of data. So do you have an example for kind of challenges that you faced in analysis of data? The example you gave was more on transfer of data and accumulation of data.
Yeah, that's great. So transfer data is a very difficult challenge with patient privacy in mind. Data may be kept in different silos within a healthcare system, and understanding how to link that data together is a really important challenge. I know from a regulatory perspective, Health and Human Services in particular is assessing that right now. But in order to analyze that data accurately, we've seen a lot of advancements in the capability of models to understand medical symptoms, diagnoses, do that more accurately. What we're seeing this year is a huge investment in the ability for these models to be used as what are called agents. So the difference between an agent and the past way in which you've used a model as like a chatbot or a co-pilot is the agent can go and take multiple steps of planning and reasoning and how it's going to access a summary of a particular set of data. It could do a lot of internal search for more fine-grained patient data, more search for internal knowledge that might be kept within a healthcare system. And so now we're we're assessing how models can use that longer analysis cycle to create more accurate vignettes or summaries of how patients are performing.
Thank you. Sorry.
Great to be here. Jyothi, thank you for hosting us. And of course, Stephen. It's great to see everyone here, specifically talking about AI. And I think the presentations previously before this panel from Angelina, Alex, Adi, and Dr. Mishra, right, all talks about a fundamental aspect of humanizing care, leveraging technology, right? So that's what we're all passionate about. That's one of the reasons why we are here. One of the main reasons that we as a company at MedAdvisor focus on is that patient engagement in making sure that at the end of the day, medication and medication adherence is only as good as the individual understanding the medication that they're taking. And unless and until the awareness and adherence is adopted in the right way and humanized, you're not going to get patient outcomes, which is essentially the last mile of care. And we leverage technology in a way where it not only enables people to have a great experience, it elevates the overall care in a way that satisfies you and me, and more importantly, advances care the way we've known about it. AI in our world is more of an enabler. It's not the core. We do use LLM, and we use specific LLMs focused on healthcare in understanding the contextual nature of the data, in understanding the contextual nature of the care. More importantly, understanding the multimodalities, because data, as Jyothi was talking about earlier, and also the point that Dr. Mishra made earlier, it has got a lot of gaps in it. And understanding that gaps, being aware of it, not expecting perfection, it's an evolution, and that's exactly what we do at MedAdvisor.
So if I understand it right, you're looking at drugs, the drugs that are in use, and what kind of side effects or what kind of complexities in a multi-pharmacy mode brings in. Is that?
Yeah, it's a great question. Specifically within that, what we focus on is when medication is prescribed, all of us have experience. When you go to a pharmacy, you pick up your medication or you get delivered to your home, you get a pamphlet in that on your medical information, right, on about your medicine. It's, in short, 1 page, sometimes it's 2 page. But then how do you exactly take that medication? There's a lot of information that goes behind that, right? One is you need to take it at the right time. You need to take it in a way where you're not mixing it with other things. Sometimes you cannot have certain food like grapefruit right before your medication. All that information is something that has to be given in a bit size, right? Not in a page. Because I, as a person, I'll tell you, I will lose at hello, right? As soon as I go past a sentence. So the information has to be available to us in snack size or snackable way. So that way, in my journey, whenever I need it, I can get that information. Whether it's dosage, the time of taking the medication, if I'm taking multiple medication, how to take that, which order do I take it? If I miss my medication, what do I do, right? I cannot pick up the phone in the middle of the night and call my doctor or a pharmacist. So how do you enable that interaction in a way where it supports my medication journey, right? So that's where we use technology, specifically AI.
Okay, thank you. Over to you, Prasun.
Yeah, I think we have used transformer-based LLMs, basically GPT, and some specialized LLMs actually that tackle different use cases during the whole development of life cycle of drugs actually. So one example will be trying to clinical trial protocols actually. It's every time you have to write a protocol, it's just a new mountain to climb. So how do we analyze existing protocols and how we can save time and resources and create that protocol. That's one. And then overall precision, how do we do the patient stratification actually? How do we use the genomics data to identify which patients will respond and which are toxic responders versus which are non-responders. So I think these are the few use cases that we have.
Fantastic. So do you currently use any of the tools to do all this? Are you satisfied with the quality of tools that you've used so far for, say, for example, patient stratification or polygenic risk assessment?
Yeah, it's all, I think it's one of the things is that, it's physicians need actionable insights, right? Actually, and then what AI gives us is suggestive answers, right? So I think it's a human in the loop kind of a model, actually. And I think and models will improve. I'm not saying they're not accurate, but we heard from the panel earlier they're not that great, actually. So it just for us, it's a tool, but there's still all the work that goes into, it just makes a certain, a certain part of the, augment a certain part of that, process, actually, whatever that process is.
Thank you. So my next question is going to focus on healthcare data. So reason I used to be a VC until the mid 2023, and I gave up my VC career, jumped into creating a company only because for once in our lifetime, it became possible to break the data silos. We had a lot of data that had been accumulated over centuries in scientific literature. We had data in medical literature. We had clinical data. There was complete silos between the different types of data. It was not synthesized together to create knowledge. And ChatGPT somehow made this possible. And when all these other LLMs came into picture, then that's when we said, not just me, but a lot of other entrepreneurs jumped in and said, yes, this is a golden opportunity that needs to be harnessed. Having said that, healthcare data is still very sparse. There are a lot of gaps, as all the other panelists also mentioned earlier on. We have data that is not complete for any one given patient. So it's unnecessary for a patient who comes into the clinic with, say, diabetes to get a complete cardiovascular panel done, or maybe even reproductive panel done. That means data by itself is not complete. And if you talk about horizontal data, that means timeline-based data, it could be hospital 1 that does one point, the hospital 2 that does one other point, and the interoperability between the two. For example, a 3.5 Tesla MRI versus a 7 Tesla MRI. So there's that discrepancy or diagnostics as well. One provider versus the other provider, the heterogeneity. So how, in all the tools that you are building, how are you tackling these problems that exist? I wouldn't call these problems, I would call them challenges. I'm facing that every day when I'm trying to pull together the data and make sense out of the data. How are you solving this?
Yeah, I can take that question. It's a great question, right? So what we typically hear when we talk about AI, right, or we hear about AI, is about coolness, the coolness factor. But interestingly, all of us in the industry, right, will relate to this. 80% of the work we do is data. And that's what powers the outcome that you get out of AI. The second piece is, if you think about specifically in healthcare, right, you don't just decide that you're going to use AI and then go look for the problem. You do the other way, right? You look at the unmet need, and then you understand the use case, and then you see where technology can be relevant. In a specific case, right, there are two aspects of data that we encounter, right? And I see that generally across the industry. One is the data that we use has to be representative of the population that we are serving, irrespective of the technology or the industry or sub-industry segment, whether it's drug discovery, patient engagement, whether it's in terms of insurance, or it's in terms of looking at how do you provide real-world care, right? So that's number one. There is bias in the data, right? I think we have to understand. When there are gaps in the data, clearly there's going to be some pitfalls there as well, right? So you have to understand whether the data is representative of the population you're serving. How do you understand the multimodalities in the data? Second thing is, how do you understand the reproducibility aspect of the data? Because the data governs what outcomes you're going to get to, right? So you need to understand the patient journey. And unlike before, where most of your care was within the provider space, care today happens in multiple layers, multiple levels, multiple individuals involved. Your nurse practitioner, your doctor, your pharmacist, it could very well be specialty care, right? And also even within the medication, your medication is delivered not just by one pharmacy, it's delivered by multiple pharmacy, right? So there's a lot of data that comes from different places. EHR systems that we talked about earlier, you don't have one standard EHR system, even though there are interoperability standards, right? So you have challenges in the industry where the technology that is trained, right, cannot be just trained on data sets that are pre-curated, right? It has to be trained on data sets, not just pre-curated, but more importantly, available in real world care, so that way you understand the nuances with the data that typically healthcare professionals deal with. When you do that, then the outcomes are closest to what we all want to get to, right? So it takes time. It definitely takes effort. And I think Adi was talking about it, Dr. Mishra talked about it earlier as well, where it is an evolution. And for that, I think we need to be comfortable to understand what the data is telling us, address the data, get the data improved. Then the outcomes using technology like AI automatically gets better in serving patients. The last thing is data privacy. Because right now, we talk about data. Data is everywhere, all around us. But the most important aspect of data is it needs to be secure and there needs to be privacy aspects. So you need to think about federating the learning of your technology so that way it understands the broader data available in a secure way, so that way you apply differential privacy to that as well, in a way where all of our data is managed, just like how we will manage our personal finances.
Thank you. Do you have any feedback or
Yeah,
inputs?
I'll agree with the general point. The real world data often looks very different than synthetic data or data that's available for academic benchmarks. And it creates big challenges now in evaluating how AI systems that have only been tested against a really clean synthetic data set actually perform in the real world. In the real world, all of our patient records all have gaps in them. A lot of times, some of the most insightful information was gathered just by today, like a clinician putting down their iPhone next to the bed and recording a transcript of what their conversation was with you, but no one ever tied together the results of that bedside transcript together with the rest of the medical record. And so you have like a huge challenge now of connecting together the dots of like, why was this particular medication prescribed? Why was there concerns about your A1C score that you revealed in a chat transcript? So tying together all the messiness of real world data is a big challenge right now. I think we're getting better at learning about the problems those gaps cause and how we can present to clinicians, whether those are nurse practitioners or doctors, the right information, the right context for them to understand data gaps that might be there, and go and request additional information or do that ahead of a visit. So hopefully over time we're getting better at filling in the gaps in advance before it becomes too late.
Thank you. So I'm going to just turn the question a little around to you, Prasun. Before that, I want to make a point. It's so real that the data doesn't just exist. For example, 20 years ago, women were not even included in clinical trials. So most of the drugs we take today were not even made for us. And even in the laboratory, only male mice were used, male rats and mice were used to test these drugs. So a huge amount of data is just non-existent. So given that scenario, what is the future for data and how do we overcome some of these existing challenges? Yes, we all want to build great LLMs using the great kind of data, not synthetic, but real-time data. Yes, we'll get there. But how do we get there? What are the steps that will get us there, Prasun?
Yeah, I think that's one of the leading challenges that we have actually, and to solve. I think data bias is one of the whatever you use whatever data you use to train the LLMs. We have seen that.
Could you hold it closer? Please.
Okay, can you hear me? Yeah. So whatever data you use to train an LLM, actually, sometimes there are biases there, especially the demographics. Actually, so if we use like a U.S. data, then it doesn't reflect the global global scenario. So I think we have to include the global data sets to basically balance it out. And I have done a lot of mouse experiments, and I learned that the male mice fight a lot actually. So at the end of the experiment, I'll lose a lot of male mice. So I did all my experiments on female mice actually, because they are more calm.
You're a trailblazer, trendsetter.
Yeah, they're more calmer. They, they're, amazing. So yeah, that's what we standardized a very long time that, we did, I think, and so that's a side thing. But then moving forward, I think all these biases, ethnic biases, that AI has, I think if we feed enough data to it, it will overcome in few years actually. Yeah.
Fantastic, thank you. So I want to change gears and talk a little bit about eval models. I think one of the panelists earlier talked about human in loop. Yes, that's an essential component, but the goal should be to move quickly away from human in loop. We are not trying to replace. I think none of the solutions we are building right now currently will replace a physician or a nurse. It's only going to augment. But then what we're looking at is slowly moving away if we want to bring in distributive justice to treatments and modalities, then we need to be able to create a wholesome system that even in absence of a clinician is able to do justice to the case that the patient presents. So having said that, what kind of eval models are you building to validate the output? Say, for example, one of the previous speakers talked about a very large chain of hospitals in India implementing AI systems. So what kind of monitoring do you think is necessary? Is there a need for international monitoring of the output? So I just want to pick your brain on all your brains on this.
Yeah, I think that's happening. So there's a lot of learnings that will come out. But one thing is that since we institutional data, right? There is also bias in institutional data. So especially from EHRs, we are learning that it's very difficult to integrate EHRs from different health systems. There is an inherent bias of how they were collected actually. So that's that's something that I have to add actually.
Yeah, I think the point you're making is a very important point. And the question you're asking, Jyothi, right, is it's nuanced, right? See, the governing bodies across the world are going to have frameworks that they're going to recommend through various policies on the use of technology. The specific monitoring of that is going to be up to the entities, right, using it, because it's going to be based on the use case. A good example, right, is you have at this given time, right, there are generally across the world, there are three aspects that are considered when it's coming to evaluation, right? One is your standard metrics that focuses on performance, it focuses on relevance, and sometimes it also focuses on precision. The second one is specifically in healthcare, right? You have to think about the clinical aspects of the nature where is this the right thing to do? And is this actually getting the outcome that we intended to do, right? Rather than just looking at the actions. And the third one is, of course, human in the loop. Right now, the system is still learning, and it's about augmented intelligence. So you have to have human in the loop to understand this was what the algorithm was expected to do. Did it do it or not? And then apply it against all the frameworks, whether it's FDA, whether it's other agencies that are defining some of the use of technology, and leverage that to have a standard framework that you can automatically look at it and say, are the intentions translating into actions? Are the actions translating into the outcomes that we all expect, right, out of the technology? So again, it's nuanced because, again, the technology is complex, it's moving faster. Specifically in healthcare, there is a level of, aspect of patient safety that has to be considered. And until and unless you put that lens, it's going to be very difficult to just do in one-size-fit-all monitoring.
So my question is more about the fact that there is a drive in the LLM field to build bigger and bigger models without a care in the world about where the data is coming from, what is the source of the data. If you're going to troll the internet and pull out 1 trillion parameters and then put it into an LLM and create an LLM, and everybody flocks, all the patients flock to that LLM, like people flocking to ChatGPT about their pancreatic cancer diagnosis, or going and asking Alexa if my diabetes can be managed better. This is what is muddying the field, in my opinion. Because internet is full of data that's not valid, data that's valid. So how do you distinguish between the two? I think eval models are not just eval models to evaluate the performance of an LLM. I think it should actually move backwards to evaluate the kind of data that is going in and the kind of output. So internally, in my company, we're building two types of eval models. Of course, one that has human in the loop, and the other eval models is automated eval models. Every time we feed a batch of data, maybe it's a similar kind of data that the LLM has already been trained on, or it's a different type of data. Say, previously we have trained it on just the disease names. By the way, there are 27,000 diseases. And if you were to feed those and train the model to recognize those 27,000 diseases versus feed the MRI data, then we have different kinds of eval models. So that was more of my question about what do you think the eval model should look like going forward?
Yeah, the point you're making, right, about data, it brings its own need for focus, right? The data labeling is an aspect that, going back to the point you're making, data's got gaps, and as such, the labeling is going to have gaps. So how are you going to train? Are you going to have supervised training, or are you going to have semi-supervised training, federated learning? Now, if you think about all that aspects, the industry is learning really fast, and so are some of the things that we think needs oversight, right? Specifically around data, 80% of the work is data, right? I mean, all of us will relate to that. It's not about writing the algorithm. It's actually about looking at harmonization of the data. It's about understanding how will the algorithm reproduce when the data sets are changing, and will you get the same outcome? And what I typically find, right, is data is the biggest factor. And if the labeling is not there, you have to think about, okay, now what do you do? Right? The data has got gaps. It's not going to change overnight. The way the data is getting entered into systems, different EHRs, different locations, variables, you name it, social media, that is not going to change. So when certain things don't change, what are you going to do? So that way you don't do the same thing and expect different results, right? So this question is spot on, but it's evolving, right? Every company now is taking it upon themselves to figure out what's the right way to solve for that for them. And of course, right, like what Vijay was talking about, and also Dr. Mishra, is we all also want to make sure that the overall industry is evolving. So what do you give back, right, to the community that is doing the research on this is a fascinating place.
And our job is to have these discussions, make sure that we talk about these problems, so that every time somebody goes on to build a product internally, they address these problems. Over to you, Vijay.
It's a great opportunity for public-private partnerships around both data. In the UK, they call these trust assurance regimes, where healthcare systems and other groups can collaborate together to share data sets that can be used to create assurances about how AI models are performing. That's emerging in the US as a trend too. And I think what's really powerful, as you said, there's both expert in the loop and expert oversight, and then there's automated evaluation models. Combining those two together into a hybrid mode is way more powerful than just doing either one alone. So hopefully in the US, we've operated under the Biden-Harris AI, the Trustworthy AI Systems Act. And so under Health and Human Services, there's both FDA and ONC, which are responsible for medical records. They've both been looking for chief AI officers and other roles. They can fill in the gaps here. Hopefully you'll see a lot more public-private partnerships as those roles evolve and the regulatory regime evolves as well.
That was 30 plus 5, right? Plus 5 was for the audience. I just have one more question.
Yeah, just whenever we'll get into questions whenever you're ready. We're trying to catch up on a little bit of time, so it's really fascinating. I wish we had like a couple hours for each amazing session with such great folks who took time out of their day and their week to join us. But go ahead, and when you're ready for questions, we'll try to not run too much over this clock here. Okay, thanks.
So my last question is, what does the future hold? And how do we make it a better future? I will go first. I think we are living in amazing times. This was unprecedented, to pull together heterogeneous data, different piles of data to get together to create knowledge that can actually be applied in a clinical setting is huge to me. And having said that, when you look at a geriatric population, I think that is where the maximum opportunity exists. Because none of these diseases, my company focuses on chronic diseases. We don't look at acute diseases at all. Chronic diseases to me are not one day you're perfectly all right, you're completely in good health, and the next day you're ill. It takes about 20 to 30 years for these to develop. And if we use that window of opportunity to diagnose early and to detect a pattern early, I think we're giving back a huge way to the patients, and we are actually helping the patients in an unprecedented manner. So I think LLMs will play a huge role in making this happen because of pattern recognition capabilities and churning of huge amounts of data that they are capable of. So my goal is to build, and the eval models, if I raise enough VC money, I will be able to make them public, just for any company to use. So that's my 2 cents. Over to you.
Yeah, I agree that there's a huge opportunity to build better test and evaluation of models across the board. But within healthcare specifically, because of so much of the data is private data and patient privacy needs to be preserved, we need to find good ways to collaborate so we can respect that, use techniques like differential privacy, and still be able to evaluate how models perform in scenarios so that we trust the outputs.
Yeah, I think the future is going to be transformative, specifically with the use of LLM, in my view. I think the areas that I definitely think is going to evolve significantly. Right now, Google is pretty much replaced by ChatGPT, right, overnight. There's going to be a level of trust that we'll have to build, right, in the technology that is being used. the area specifically is going to be significant changes. Patients are now more beneficiaries of care. They are active participants in the care, which means the patient engagement has to be personalized. The second piece that I think is going back to the point that Nitin was talking about, in the engagement, you have to think about not just one and done. It has to be about the journey the patient is taking, and you have to understand the journey. And I think the LLMs are going to play a big role because it's very easy to stitch because they are all built for data. Data is the core aspect that today AI does really well across the industry. And the last piece is, see, I think humanizing care, it's not just a terminology. There are a lot of aspects that go in that. Now, the privacy aspects of it and patient safety aspects of that has to be accounted. I don't think there is quite amount of work that has gone in there. And I think when that aspect is taken care of, I think this is going to be quite elevating in the overall experience. And that's where I think the health equity, affordability, accessibility of the care is going to be addressed across the world, not just in US.
Prasun, over to you. But we've run out of time. So let's make it short.
Yeah, I think, I would leave you with this actually. When, I have dealt with both tech world and the biotech world and pharma world, and tech entrepreneurs come into healthcare and they say we'll disrupt healthcare. Actually, that's and then healthcare is a very complex ecosystem. Actually, it cannot be disrupted. Actually, when it comes to LLMs and so I think there is a big potential for focused use case based LLMs. Actually, for every aspect of every stage of healthcare. Actually, a few examples are real time clinical decision support, personalized medicine through multimodal data, synthesis and automating administrative tasks. Actually, this is throughout the pharmaceutical and care. Actually, if we can achieve that, that'll be a great, great achievement. And then. Improvements that are needed actually are again domain-specific LLMs building, and then the second will be, I think, addressing ethical and regulatory concerns. Actually, that's some of the key problems right now. And lastly, enhancing models' ability to interpret multimodal data at scale. Actually, so that's these are the few thoughts that come to mind.
Thank you all so much. It was a fantastic panel. Steve, do we have time for questions from the
let's just get 2 questions because we are falling behind. So it's constant game of catch up. Go ahead.
I was wondering what you see as like agents in like AI evaluation for the future and like for data sets.
I'm sorry.
The role of agents in AI evaluation and data sets. Yeah, it creates a lot of opportunity because, compared to the way models performed before, where they would effectively leverage all this pre-training data that went into training the models and then some context that's passed in, agents can now create really complex, sophisticated, long horizon plans about how they might answer a question, and then backtrack if they realize they don't have the right data to support a conclusion or they summarized a particular finding incorrectly. So we're just now learning how to evaluate how they perform in those more sophisticated tests. It's way more complicated. There are a lot of challenges that introduces, but I think that's where this hybrid approach of having experts in the loop together with agents evaluating themselves is going to be really important.
And also it takes away a lot of latency and brings in specificity and accuracy.
And let's get one more question, and then we'll just have one burning question and one burning answer. Okay, raise your hand.
Jyothi, and thank you to all the panel. It was super interesting. I was for many years at Google, so I'm very interested in what you say, harmonization of AI, right? How do you think this can be solved? Because this is the Pandora vase, right? Having the right data sets and train the model in order to respect all different point of views and everything, and not having huge bias like we have seen with Gemini or other AIs.
Yeah, so he has asked me to give answer in one word or one sentence. That's going to take half a day for me. That's a very interesting question. I'm happy to talk to you at length about it.
Well, it's a good thing. Not only will you be here through the day, but you'll be here through the party, right?
Hopefully.
So everybody knows they're invited to stay for the party after. So we hopefully will get all our programming through by 7, and then we'll have Tesla test drives and the big party after. I want to give a big hand to the panel here. So Jyothi, Vinod, Vijay, Prasun, thank you very much.